So the first group of drugs that we're going to talk about are the typical antipsychotics or the first generation drugs, all of which are listed here on the right. You don't need to know the chemical distinctions of phenothiazine or butyrylphenone. That's just there to demonstrate that basically there are different drugs that have the same kind of chemical properties, but they all, as a class, have a preferential blockade of the D2 receptor compared to the serotonin receptor subtypes. And so that's the thing that kind of distinguishes them from the other class. Obviously, it's the opposite for the atypicals. And so from a historical standpoint, these were really kind of the frontline therapy for schizophrenia in the 1950s. And so if you ever see any old movies, One Flew Over the Cuckoo's Nest with Jack Nicholson, or any of the stereotypical kind of portrayals of patients with schizophrenia in hospitals and mental institutions, the vast majority of those patients were on these types of drugs. These are older, and over the years we've kind of seen them shift or expand into other disease states. And so they, as a group, they offer profound blockade of the D2 receptor. There's also some blockade of the serotonin receptor, as I said before, and these drugs are great for treating the positive symptoms. They're also great for the acute psychosis management. And so earlier I mentioned haloperidol is a great drug in kind of emergency situations where patients are suffering from an acute psychosis. Haloperidol will basically kind of restore the balance of dopamine and acetylcholine, dopamine and serotonin, and basically stabilize their mood. From a chemical standpoint, if you guys are into chemistry at all, they have a high degree of resemblance to tricyclic antidepressants. And in fact, many of these drugs were the kind of the forerunners to the medicinal chemistry that made tricyclic antidepressants. We can also kind of subdivide them into high potency versus low potency. The highly potent drugs include haloperidol and the FLUs, so fluphenazine, trifluoropyrazine, and others that have similar names, but those are the main ones. These offer a really potent D2 receptor blocking, and they're associated with a high degree of side effects called EPSEs, which we'll talk about later. The lower potency drugs include thioridazine and chlorpromazine. These have a much lower incidence of these excitatory postsynaptic type of erratic movements, but they also offer a higher degree of affinity to the serotonin receptor blockade and also to other neurotransmitters. And so there's a lot of kind of messy overlap between all of these drugs. As a group, they also have relatively long half-lives. The vast majority of these drugs are administered just once a day, and they offer pretty good CNS penetrance. And so they get into the blood-brain barrier, they get through it based on the lipophilicity. But as a class, they can also affect other receptors. And so fluphenazine has well-documented alpha antagonism. Chlorpromazine and thioridazine offers some muscarinic receptor blockade. Chlorpromazine and thiothiazine also have H1 receptor blockade ability. And so in the CNS, of course, that translates to sedation. There's also a handful of drugs within this category, two of which are listed here, that can alter eye physiology and in higher doses can produce eye pathologies. Haloperidol is a really interesting drug. It's an old drug. It's the drug that we suspect Van Gogh was on when he painted some of his more well-known pieces of artwork. Chemically, we said it's a butyrylphenone, and it acts like a typical antipsychotic, and so you get very profound antagonism of dopamine subtype 2 receptors, but also a slight antagonism of some of the serotonin receptor subtypes as well. You see some alpha-2 antagonism, and you also see some muscarinic antagonism as well, but it's relatively minimal. It's a really old drug, we said. There's lots of experience, and it's got a really high therapeutic index, even though it is a centrally acting drug. It's really great for the treatment of positive symptoms in schizophrenia, as well as the manic phase of bipolar disorder, aspects of Tourette syndrome, particularly tics, Huntington's disease-associated chorea, and in general agitation. But the major side effects are these extrapyramidal side effects, which we'll talk about shortly. In terms of other side effects that are associated with these first-generation agents, obviously the neuromalignant syndrome is a big one, and that, again, is stemming from its dopamine receptor antagonism. Many of these drugs also affect prolactin. As a side effect, they can produce gynecomastia. They can also produce impotence as well in men. Many patients, especially with some underlying cardiac dysfunction, you can see the production of torsade de pointe, as well as the production of seizures in other patients. And then they can also produce what's known as tardive dyskinesias, which I'll define later. The lower potency drugs as a group offer less dopamine receptor antagonism, but you see highly associated other receptors, so histamine, muscarinic, and serotonin. And so the main side effects you see with these drugs include sedation and orthostatic hypotension and the possibility of tachycardia. I like this summary slide that talks about the adverse effects of these antipsychotics and their supposed or proposed mechanism. And so in terms of the autonomic nervous system, we can see a loss of accommodation. We can see dry mouth. We can have the patient complaining of difficulty urination, as well as constipation. And a lot of that is coming from the off-target binding of muscarinic receptors. Orthostatic hypotension and impotence, as well as changes on EKG, are suspected to derive from alpha-1 receptor antagonism. And then the other adverse effects can be seen in the CNS. We can see Parkinson-like symptoms, including movement disorders, which we will talk about shortly. And a lot of this comes from the dopamine receptor antagonism or the supersensitivity of the dopamine receptors due to persistent alteration. Confusion typically stems from muscarinic receptor blockade within the CNS. There's also an endocrine type of adverse effects coming from dopamine receptor blockade in the periphery, and we can see metabolic alterations coming from what we think are more serotonin and possibly histamine receptor antagonism as well. And so some of these adverse effects can be treated appropriately. So, for example, dry mouth can be treated with gum, water. There are some OTC drugs that can cause a rehydration of the mouth. Constipation, of course, can be treated with fiber and prokinetic type agents. Orthostatic hypotension, coming from alpha-1 receptor antagonism, can be treated with more water, a little bit increased salt intake, and then telling the patient to slowly change position so that they don't get lightheaded and dizzy when they stand up. The Parkinsonian symptoms can be treated with benzodiazepines. They can also be treated with intravascular or intramuscular anticholinergic type agents. The tardive dyskinesias we will talk about later in this lecture. EKG changes should be monitored and then treated as needed. Impotence and infertility could be treated with IVF, of course, or in men, erectile dysfunction type drugs. And the hyperlipidemia can be treated with diet and exercise or simply with a statin. And so these are the main kind of side effects and adverse effects associated with antipsychotics and some of the ways in which we can kind of treat them, because it is better to treat the psychosis and then just kind of manage some of these side effects as they kind of manifest themselves.